Good afternoon. Thank you for allowing me to come and be with you and be a part of your success. I'm always inspired when I have the occasion to come and walk and talk and be with young people. For as I've said numerous times, I am of yesterday, you are of tomorrow. You give me such great hope, and I have such great expectations of you. And it was not ill-founded when I had the opportunity to talk to the graduate students yesterday. Some of them were a little shy about looking me in the eye, and all I'm doing is trying to read the windows to your soul, to see how I can turn you on and keep you going forward. You represent such great promise. This is a wonderful opportunity for me. And I've chosen the topic for today's presentation. I could have named it anything. I could have said about you. That was a good title, about you. I could have named it my journey. And perhaps you may want to name it a little bit something differently. But a large part of what I want to talk to you about is what has motivated me to start from whence I come to where I am, having started, as many of you have, in very humble beginnings. No real books in the home, very little educational background from the family. And so, yes, I am a spiritual man. Make no mistake about it. And I often say, by thee I rise. By thee I rise. To have come from whence I have to where I am now, having been at the National Institutes of Health for all of those years, and to have worked in every state, to having had an impact in thousands of universities around this country. I'm on a divine journey, one that actually has been charted for me. I'm just working out the script. That's all I'm doing. But I've chosen for you today the title, Translational Research in Health Disparities. In my view, it is the nation's responsibility. It is a nation's imperative. It's what we must do, because the health of all people is critically important to the growth and well-being of this country. And I have walked this journey, I have fought on this journey, and in fact, there are many successes. You represent one of them. This notion of translational medicine, translational research or translational medicine is not a new concept for me, because in the quiet of the night, as I pursued and chased those molecules or tried to get those products from those many chemical reactions, I thought about, what is my real purpose here on earth? How can I leave big footprints in the sands and make a difference in the lives of all those that I touch? So I used to think, and I still dream, for I have dreams unmet, but I still dream about yesterday. I want to start by telling you that in my lifetime, there are a number of seminal events, things that happen in science that has made a difference in how medicine itself can impact on the lives of people. And I guess we go back to 1952 when Watson and Crick actually talked about the alpha helix. And from there, as you know, it led to DNA, RNA, proteins, et cetera, et cetera. We began to understand the foundations, if you will, of life. This is what I believe was a critical step. And then in 1963, the description of the self-renewing activities of transplanted mouse bone marrow cells. This was another significant step in the progression toward human disease, treatment of human disease. This has been used in patients receiving radiation and chemotherapy, stem cells, the beginning of the pursuit and understanding of stem cells. The next seminal event that I want to call to your attention is that in 1998, a scientist at the University of Madison, Wisconsin, successfully removed cells from spare embryos at fertility clinics and grew them in the laboratory. I'm a scientist, make no mistake about it, but I don't ever think we're going to be able to produce to full term an infant without a woman. Now, I believe that. I believe that. Now, you guys, long after I'm gone, may do that, but till you get there, I'm not a believer. And point of fact is, I often equate some of the advances in science to what happened at the Tower of Babel. Some of you know about it. And when we got close to the real truth and understanding, what happened? They were no longer able to communicate with one another. We're so far from here, and it's actually thought that the mapping of the human genome was a substantial step forward, and indeed it was. I really thought, and I was right there in the midst of the National Institutes of Health. I really thought that if we mapped the human genome, we got the answer. That's the Holy Grail. And now, after we got the human genome mapped, what did we conclude? It is not that simple, folk. It is the constellation of genes and gene products that ultimately affects human development, human understanding, and human behavior. And so the NIH was involved with the mapping of the human genome, but it opened so many, it actually unraveled and caused us to to address many questions. However, as a result of these events, medicine of today is far more predictive, far more personalized, and as I talked to one of my organic chemists, I don't see him here just yet, he's here, it is now predictive, preemptive. We can actually go in there with those molecular wrenches, turn on and turn off various genomic events in order to control, prevent, and modify disease manifestation. Let me talk to you about what created my interest in translational research. Well, the first thing was when I was a graduate, the first thing was the synthesis of quinoline and isoquinoline. Young people, I didn't have all the advantages that you do, all of the instrumentation, all of the faculty help. I didn't have that. The March on Washington Jobs and Freedom in 1963, yes, I was there. And I began to think, how can I impact on the world? And the isolation and characterization of triterpenoid glycosides. That was my dissertation research for the PhD. And studying in the biochemical, lecturing across the state of Louisiana on the biochemical basis of sickle cell disease. I thought it was my responsibility as a scientist to go out and help people. So I was in churches, I spoke at the Tulane LSU. I did not know that they call this grand rounds. I was just going to talk with them about scientific advance and how, in fact, people need our help. I became a member of the first African-American, if I might say, member of the American Heart Association of Louisiana. I was invited to membership. I don't need membership, I need action. And so we actually developed a project where we were looking at, it was a longitudinal study looking at the effect of the roles of triglycerides, lipoprotein profile, combined and uncombined cholesterol, glucose in the progression toward heart disease. And we actually had begun to develop and analyze the blood of the entire freshman student population. That was when I left Southern University and went on to to do some additional things. And when I worked with Eli Lilly, with some of the giants in diabetes, Steiner and his co-workers, Mary Root, Ron Chance, actually developing a radioimmunological assay for proinsulin and triiodothyronine, two research projects that I was a part of. And then, I guess, 3 decades at the National Institutes confirmed that I was on the right path. Just for my organic chemist, I thought I'd simply put up here how quinolines are synthesized. And in fact, it's a combination of aniline with beta diketones, I believe it is, with the catalyzed conversion of the ring formation with sulfuric acid, ultimately leading to these products called quinolines. And they have found their place into medicine. This is the kind of compound I was working with when I was a graduate student in biochemistry. I was involved in the isolation and characterization of triterpenoid glycosides. And in fact, I learned, and everything I did in graduate school, it was through my own effort. I really didn't have much of a mentor, but maybe that was good. It made me seek the truth. I found out that these were the same compounds, classic compounds that are used by Aborigines, Indians, that actually stop the heart from beating. And so it has been demonstrated thereafter that these compounds have beneficial effects. They're found in many of our food sources. They have a direct effect on blood cholesterol levels, cancer, bone health, and stimulation of the immune system, but can be, as most things, very detrimental to life itself. And I did tell you I was at the March on Washington for Jobs and Freedom at Martin Luther King. I was there, graduate student, and that helped shape my life and my career. And so I decided for the years thereafter, I would make a difference in the lives of people. The 37 years, now the 37 and a half years I spent at the National Institutes of Health was a tremendous experience for me. And when I got there, I learned full well about the mission of the National Institutes of Health. The mission of the National Institutes of Health is to evolve new knowledge for the improvement and betterment of the health of people. I said earlier, I felt very strongly that that meant me too. And so recognizing that most of us was not embraced by that agenda, I thought I'd do something about it. And that led to my doing a number of things. This is simply a reiteration of the NIH mission to evolve new knowledge. And it's a wonderful place to work, some $30+ billion, about 20,000 people, and supporting researchers throughout this country and the world, the National Institutes of Health. Secretary Heckler referred to the National Institutes of Health as a jewel in the crown of HHS, and indeed it is. Pushed back the frontiers of science and made life better. And my concern was better for us too. And so I spent a lot of time trying to use those resources, learning how to actually better the lives of people. These are the examples of the kind of things that the National Institutes of Health does. Determine the biological effects of environmental contaminants, and in fact, you ever thought about what happens when your tires wear out? You ever thought about that? Well, it gets on the highway, and the next thing, the water washes it into the drain system, and it becomes a part of your water supply. Environmental contaminants. Exhaust from automobiles. It gets into our air. And so these are critical questions as to what we can and need to do. Now, point of fact is, much of what happens in society, in fact, is a representation or a result of progress. I can't imagine how long it would have taken me to get here from Chicago if I were in a horse and buggy. So I flew. Progress. I can't imagine whether or not I could have done all the things I've been able to do and worked in every state without the advancements of modern science. So, let's talk a bit about some opportunities for translational research. And this is simply a summary of all the things that I did. And I didn't have really any ideas when I first got to NIH, but I knew that with these resources, I could find a way. And so these are all the many programs that I was associated with, and in fact, much of this is my vision. But it's my vision, not my vision, it's my interpretation for you, your vision. That's why I came out here. One year flew 40,000 miles just to learn from you. What are your needs? What are your challenges? It's no need in us building these magnificent edifices without resources to do the research. And if you don't have researchers, we need to provide you support for researchers. And if we have the researchers here, we need to give you some money for the researchers to start down the road. And if they don't know how to write papers, we need to teach them. For they too are scientists, and they too are capable. And I believe that through these many efforts, we have been able to make an impact, not only on minority institutions. I had grantees at Harvard, grantees at the University of Washington, grantees in Oregon, yes, Minnesota. But I thought it was also important to have grantees here in these places, because you too deserve that same opportunity. That was my career. That's my career summarized. And in fact, it wasn't easy. Started out managing $4.7 million. I really thought that was substantial, and indeed it was, coming from zero. Zero to $4.7 million is significant. But when I left NIH, the budget I was managing was like over $300 million. And I guess in 10 years, we're talking about $3 billion. 20 years, $6 billion. 30 years, $9 billion. That was my responsibility, and I took it seriously. And I was just so glad that I was on the point and carrying your flag. This is just another way for you to see the impact of my effort. And this does not include SCORE, RISE, NARCH. Those were also programs that I was responsible for. A program for Native Americans. SCORE, RISE, I was involved in that. And so this is just another way of saying my career. This thing called translational research, I don't want to leave you thinking that it all begins in the clinic. No, it doesn't. The foundation of clinical research advances, more often than not, begins with basic research. But sometimes it comes in the reverse direction. A physician makes an observation and then backtracks, and I'll show you some examples. These are the programs that involve basic research. Then there was the RCMI and the Centers of Biomedical Research Excellence. That actually was a movement from the basic science into translational science and ultimately clinical research. I'll talk to you a little bit about clinical research. And what this is summarized is T1 to T3, but there's also T4 research advances or research initiatives. T4 is when observations are made by public health nurses or so forth within the community. And they themselves begin to come to the ivory tower and they pursue various research questions. This is another way of summarizing that research paradigm. Yes, animals are important. Yes, instrumentation is important. DNA, RNA, protein, I've talked about that. And ultimately, to make life different in the community. This all began for this community, I believe, when Secretary Heckler appointed a group of people who, in fact, were charged with the responsibility of looking at the health of the nation. How are we doing? What is our report card as a nation? And in that report in 1985, Secretary Heckler's report, it points out that there is wide disparity in the incident of disease and death in certain populations in this country. Hispanic Americans, African Americans, Native Americans, Asian Americans, as a result of their experiences and the resources that have been provided, die more frequently, are affected more dramatically by various diseases. And we could do better as a country. This is Secretary Heckler's report. And so in 1985, the Congress laid out an ambitious agenda through this report, and it led to the birth of the RCMI program, Research Centers and Minority Institutions. I was not a part of the development of the initial program. This emanated from the community, but point of fact is, I rolled up my sleeves and became very much a part. The reason why we need to look at this thing called health disparities from a scientific point of view. You know and I know that if we're looking for gold, we go to a gold mine. If we're looking for a needle, we don't look in a haystack. And so as a scientist, you know and I know that if indeed we're trying to understand the mysteries associated with the incident of diabetes, we ought to look where it is most frequent. That's in the various minority populations. We need to and really see how better to serve that community. And in so doing, we understand how to serve the majority community better too. And at the same time, you know, we actually are decreasing the cost of health care, which affects, it becomes a serious pocketbook issue. So health disparities is critically important for our nation as a whole and us in particular. The Academy of Sciences pointed out something. This is for the young people who are planning a career, that these are some of the other factors, not only the genomic kind of information, but language barriers oftentimes affect clinical care. And nothing is worse to go to someone as your primary care physician, and they don't even understand who you are. And I'm afraid that oftentimes, and this is just the way it is, without the right physician, oftentimes the treatment of choice is not provided to us. And we suffer premature, debilitating diseases and ultimately death. Because in the mind of that physician or that healthcare person, it is not important to save our life. That's tragic, but that's the way it is. So we certainly need physicians, physician scientists who speak our language, who know our culture, and understand us. And sometimes the treatment is simply being able to be compassionate and care for the individual. Bias among doctors and nurses, I've already talked about that. And I know that early intervention with drugs in various stroke conditions actually is a major step toward the healing process. And all we have to do in the emergency room is administer the medicines. Or we could delay the administration. Don't think that patient deserves it. Do not need to care for them. And so the patient lays there and they suffer adverse consequences. So we do need minority physicians, but we also need somebody to take my place, minority scientists, to actually make decisions that are in the best interest of our communities. This is simply census data. This is critically important. President Obama recognized this. That's why he won the election. He knew that the face of America was changing. The population is changing. And so by 2050, this is what the U.S. Census projects. Let's talk about the 10 leading causes of death in the USA. Disease of the heart, malignant neoplasm, cancer, chronic lower respiratory diseases, pulmonary diseases, cerebrovascular diseases, stroke, and accidents and unintentional injury. And Alzheimer's is becoming a major part for all people in this country. I don't believe at this point that, and diabetes, of course, I don't believe minorities are suffering disproportionately in terms of Alzheimer's. I don't believe, I don't know. I just wanted to know, how are we doing in Texas? How is Texas doing in terms of disease manifestation based on those 10 things identified? Well, I think if we look I think that's what you told me. There we go, there's Texas. Out of the states in this country, Texas is 30 and 34th in terms of the incidence of cardiovascular disease and diabetes. And point of fact is, I guess we really need a lot more health care here in this state. We really do. No, not we, I'm leaving. You really do. You really do. And there are some states that are doing exceptionally well. Minnesota. Well, I don't subscribe to the fact that Minnesota has the Mayo Clinic or Utah has such a wonderful medical school. It's actually how we have gone out there. I don't think anybody really wants to have disease. We have failed to go out there in the highways and byways. We've stayed too much in our ivory towers and not going out there and helped our people, teaching them. We can teach them on Sunday. We can teach them in the evening. We can teach them in many ways how to care better for themselves. I don't think at-risk behavior is simply a matter of the individual, but they don't quite understand. How many of the people out there in our community understand that nicotine activates aryl hydrocarbon hydroxylase that promotes the growth of cancer cells? How many people know? How many folk out there know that? Maybe not many in here either. I don't know. So they smoke. It becomes a matter of fashion. It may be because they need the great escape. And so they kill themselves daily. Alcohol, cirrhosis of the liver. They don't know. We have to help them. And I believe we can. So we have a lot of work to do here in Texas. Those of you who are here, from here, and who will remain here, in terms of helping to upgrade, elevate the level of the quality of life for our people. It doesn't matter how long we live if we don't have a quality life. So we need to, yes, you're busy, and I guess the graduate students are really busy trying to get that blame degree. But while you're getting that degree, start thinking about, what am I going to do with my life, and how am I going to make a difference? I better step on it. Here are the 10 leading causes of death for African Americans. And the reason I went right through the first one, as I go through the second one, it's the same diseases for all three groups. The top 10 diseases: cancer, heart disease, stroke, unintentional injuries, diabetes, influenza, and pneumonia. There are other at-risk populations vis-a-vis geography, the people of Appalachia, gender. Some diseases disproportionately affect women more so than men, and vice versa. Age, disability status, and so forth. I'm leaving the slides behind because I want you to take time to click on this website and look at all of the health data you could ever imagine you could want to know. And all you have to do with these slides is put it in the slide mode and click on, it takes you right to the wonderful internet. The big three threats as was outlined, is obesity, chronic disease, and smoking. Obesity, the biggest threat to our health today. I concluded as I walked around and people that I've interacted with here in Texas, we're doing okay. Maybe I'm not, but you're doing okay in terms of your weight. And so we've got to somehow find a way to treat ourselves well. You can run if you like, and at some point you're going to start just walking because you've worn out all the stuff that separates bone from bone. But you can walk forever. You can go to the gym. I don't like to be indoors, so I'm not a gym rat. I'm not pumping iron. My sons do. But there are ways that we can deal with this problem of obesity. It's one of the fastest growing health issues in the nation. As you are aware, it contributes to heart disease, diabetes, general health. 27% of Americans are obese now as compared to 11% in 1990. We're getting bigger and bigger and bigger and obese, heart disease, and in fact, many of our health disease. And one thing I can say about my colleagues here in Texas, San Antonio, you sure like to feed me. I have been eating more. I've been trying not to eat so much, but I love food, as you do. It is predicted that if current trends continue, 40% of the population will be considered obese by 2018. That's 2 out of every 5 people. 2 out of every 5 people. And not only are we drowning in adipose tissue, we're going to be drowning in debt to care for all of the people who need to be treated somehow. This is all about what happens in diabetes. And it talks about, and I apologize, but I couldn't figure out how to keep the blue-black background and see what was there. But if you click it on and turn it to white, you can see everything. So I apologize. But diabetes is saying here that by the year 2020, it is estimated that $500 billion will be spent on treatment and care for diabetes. And I have diabetes, and I take drugs, prescribed drugs, I should say. But point of fact is, I started very late in life dealing with this problem. Certainly you don't want to end up with amputations, heart disease. You just don't want to. Young folk, I would be so sad to come back and you tell me I now have diabetes because I didn't take care of myself. But you will, you're a scientist, you will. Smoking. I have not seen a lot of smoking in Texas, I really haven't. But point of fact is, in the sovereign state of Maryland, it has been outlawed in public places, smoking. It's against the law. Restaurants, casinos, wherever you go, public places, no smoking. That's the way it is. And you can smoke in your house. You can make your house a cancer ward if you like. But I'm just delighted that I don't have to live with people smoking all the time. This is just a ranking of all the states in terms of these various factors. Texas is number 44. Cause of death in the United States. This is simply saying some of the same things over. The major causes: heart disease, cancer, stroke, chronic obstructive disease. Infant mortality, a major problem. And especially, infant mortality is a major problem in the African American, Hispanic American, and especially American Indians. And part of the contributing factor is not being able to get there and have a physician help you along the way in terms of caring for yourself, as well as young girls are girls younger and younger and younger are becoming mothers. And so infant mortality is going up as a result of that. Disease of the heart in women. This is a major problem for women, and it appears that Hispanics, you're doing quite well. American Indians, Alaskan Natives, and so forth. But I'm not sure if anybody in here can classify themselves uniquely in one of these categories. Turns out in my case, I have Caucasian heritage, have American Indian heritage, I have Irish heritage, and I believe Negro. Stroke, major problem. 40% more likely to die are black people. And that's a large contributing factor is diet. Diets rich in saturated fats. That's why when I eat my fresh pork, I do eat it, I actually put it over a grill and really melt the fat. It's called barbecuing. But melt the fat where it actually leads to meat. It's not the protein in the pork, it's the fat that gets you down. Native Americans, diet again, Hispanic, oh boy, some of this Espanol foods I've been eating, they actually are rich, delicious, and cause major problems. Kidney disease. No one should ever die in this country from kidney failure. Now, that's what I've been told by nephrologists. However, if you're not getting dialysis, if you're not getting kidney, you're not on the transplant list, and that's probably political too, I don't know. I haven't had to deal with that. But if you're not getting proper treatment, you will die. End-stage renal disease. Here's the incident of end-stage renal disease. Blacks, Native Americans, Asians, Hispanics, and non-Hispanics population. Here's the gross estimate of the cost due to end-stage renal disease. As we can see, without minorities, the number goes down. The excess cost as a result of minorities makes it 77% greater than the rest of the population. Cancer continues to be the leading cause of death in the U.S. CDC estimates that if tobacco use, poor diet, and physical activity were eliminated, 40% of the cancers would be eliminated. But I do want to tell you, cancer is not a new disease. Some of my folk working at the Smithsonian Institute, anthropologists, they actually have demonstrated in looking at bones, MDs, that cancer was here back in the times of the Romans. So cancer is not a new disease. But this just talks about the incidence of various cancers in women and men. And if you look at the top, prostate, lung, colon, urinary cancer are all about the same in men and women. HIV, a growing problem in this country. HIV. If you're like Magic Johnson, if you will, you can take all the drugs of choice and actually live a full life. And so it is estimated that 42 million people around the world are living with death. And I think something like 1.6 million people die every year now from HIV. In this country, the number of deaths has gone down because of the access to drugs of choice. But that's not true around the world. 41.8 people are living around the world, and this is the distribution by women, children, and men. Some ways to address health disparities. I want to talk quickly about clinical research, and I know you're students, some of you, and when the bell rings, you get up and run out. And if you do, I'll never forgive you. But as one of the things, one of my visions for the RCMI program and the IDEA program was to actually take the advances of our researchers from the bench to the bedside, to the clinic, and out into the community. And so we began to do that as I was leaving. Here's an example of something that is being done in one of the programs I managed in Louisiana. We actually were able to bring together LSU Health Science Center in New Orleans, LSU Health Services, Tulane, Xavier, and brought these institutions together to address a major problem. And if you think people worship food in Texas, go to Louisiana. And so hypertension, diabetes, cardiovascular disease are major problems. Stroke, etc. in Louisiana. West Virginia was able to work with the people in West Virginia, the Health Science Center in West Virginia, and facilitate the coming together of 4 states, West Virginia, Ohio, Kentucky, and Indiana. The healthcare systems have come together to actually deal with the problems of the people of Appalachia. That is one of the poorest regions in this country. And in fact, to actually address the needs of these people in order to deal with their healthcare issues. And indeed, we provided through the program I managed support to West Virginia and CTSA, of which you have one over at the University of Texas Health Science Center. This is what we did in the RCMI program. Part of my vision was actually to facilitate a coming together of the basic sciences, the clinical sciences, and doing about something, translating research advances, bench bedside, into the community. 5 locations. This time is running out on me. Community engagement. I'm assuming I'm supposed to stop by 6 o'clock, so I'm trying to get through this.
6:30.
Okay, not gonna happen. Community engagement. One of the projects I was involved with, I talked about when we were doing a longitudinal study, but I also was out there lecturing in the highways and the byways. Community engagement, critical. And here's an example of community engagement. A bunch of public health nurses found that there was a problem out there in the community. They actually were able to show that there was an adverse incident, a high incident of lung cancer in the people out there in Appalachia. They brought this epidemiological information from the community into the University of West Virginia Health Science System, and in fact started a whole new project. In Alaska, another one of the projects that I supported, in Alaska, what we have found is, what they found was that the people, the Alaskan natives, as a result of converting to our way of living, instead of eating the blubber and so forth, eating Crisco instead, they became more and more problematic in terms of various diseases. Obesity, cultural understandings of health, diet and nutrition are part of this study. And they're out into the villages talking, working with the people in order to help them deal with. I think I've already said this, so I'm gonna move on. I want to talk, lastly, I think, about the RCMI translational research, because I think one of the critical things that needs to be done is to actually have a critical workforce actually pursuing critical mass of people doing research. And none of the RCMI institutions have that critical mass. That's just the way it is. And so what we have done is we put together something called the RCMI Translational Research Network, where all of the institutions have been networked over the internet using a supercomputer in Jackson, Mississippi, where various groups of people interested in various research projects have come together and can pursue. And in fact, there are many applications that I understand are now being developed collaboratively over the internet. Well, that's why we have the internet. And so This thing called the RCMI Translational Research Network is critical, I think, in terms of the critical continued growth of the RCMI program. And what happened was we had a number of little pieces, all of these little acronyms, we brought them all together and made it into one piece. This is simply an example of what the RCMI Translational Research Network does. It brings together the basic sciences, the clinical sciences, and has educational component to actually reduce and eliminate health disparities. To me, one of the successes of the RCMI program. The last thing I'm going to talk to you about, because I know you have thousands of questions that you'd like to ask me, I guess, is the fact that one thing that this was so important was nobody believes that it could be done. And so we had to do what is called proof of concept. Proof of concept, proof that it worked. And two institutions came together and conducted a multi-site clinical trial, looking at the role of vitamin D3 in terms of cardiovascular disease. The thing that happened is they were successful in the enrollment of people and in fact moved the project to completion and now writing up the advances that emerged. This was done, one of the investigators in question was a guy named Gary Gibbons, who actually moved from an RCMI institution, now directs the Heart Institute at the National Institutes of Health. The Heart Institute is the third largest institute at the National Institutes of Health, about $3 billion, Gary Gibbons. So why don't I stop here? I'll leave all the slides with you, and I'll be delighted if we can stay as long as you like to answer whatever questions you have about anything that I talked about or anything you always wanted to know about. Thank you very much.